This patient had a good color, was warm and dry, and had a full, regular, slow pulse. During the operation, she has become pale. Her forehead is cold and clammy with sweat, and her pulse is rapid and feeble. She is suffering from operative shock. Another useful sign of shock is called delayed capillary return. On pressing a finger to her forehead, we find it takes more than 1 second for the color to return to the skin. When shock is fully developed, as in this case, remedial measures may not prove entirely effective. For the early detection of impending shock, we rely on repeated observation of pulse and blood pressure recorded on a chart. Here is the chart of our patient who developed shock. Note the progressive fall in blood pressure, especially in pulse pressure, the difference between systolic and diastolic pressure readings, and the progressive rise in pulse rate. At this point, the clinical signs of shock appeared: pallor, coldness, sweating, feeble, rapid pulse. Operative shock is more easily prevented than cured. To be able to prevent it, we must have some idea of its causes. Dehydration and heat loss are important factors. Dehydration due to excessive purging before operation is, or should be, a crime of the past. Drinks, preferably glucose in lemonade or tea, may be allowed up to not less than 2 hours beforehand. Fluid loss during anesthesia, mainly from the lungs, may be reduced by using a closed technique with carbon dioxide absorption. This also reduces heat loss. The anesthetist must see that the patient is kept covered, not forgetting a shawl or towel round a bald head. The ideal theatre temperature is 72 degrees Fahrenheit. If it's too hot, the patient may lose fluid from sweating. Respiratory obstruction, struggling, vomiting don't matter a great deal before a minor operation, but they exhaust the patient, and in a severe or a prolonged operation, shock may come on sooner than would otherwise be the case. Ensure quiet by inducing anesthesia with an intravenous barbiturate. Don't hurry the introduction of ether, if this is to be the main anesthetic. You are then less likely to meet with laryngeal spasm. Some surgical stimuli, such as traction on the mesentery under light anesthesia, are more prone than others to produce shock, or at least to combine with other factors to produce it. The immediate reaction is a sudden fall in blood pressure, often with a slow pulse. Provided the stimulus is not too long sustained, spontaneous recovery will often take place, as in this case. Rough handling always leads to blood pressure fall. Remember, it may be your fault for not producing adequate muscular relaxation. The reaction is less marked under deep general anesthesia, and least after the complete block provided by spinal anesthesia. For abdominal operations by an inexperienced surgeon, spinal with nitrous oxide and oxygen is the combination of choice. Exposure of bowel and mesentery is another cause of blood pressure fall. The assistant should cover exposed bowel with cloths wrung out of hot saline. This chart shows the typical fall in blood pressure resulting from exposure of the chest wall after radical mastectomy. As much as possible of the bare area should be covered by hot saline packs. In such a case as amputation through the thigh, it may be impossible to avoid a reaction when final severance takes place. This can be reduced, however, by deep anesthesia at the appropriate moment, or if the surgeon injects 1% procaine freely into the sciatic nerve before it's divided, or around the hip joint before disarticulation. Prolonged deep anesthesia contributes to shock. Where great muscular relaxation is necessary, local anesthesia should be used to achieve this. If that's not feasible, reduce the depth of anesthesia wherever the operation permits. The less anesthetic you can use, provided satisfactory operating conditions are produced, the better for your patient. Prolonged suboxygenation may lead to depression of the heart muscle and of the vital medullary centers. Always pay the closest attention to the airway. Give not less than 16 or 17% of oxygen in the mixture with nitrous oxide over a long period. Give more if there's any sign of cyanosis or when, as in this case, a fall in blood pressure shows a deterioration of the patient's condition. It's your duty to supervise any movement of the patient on the operating table, which must be carried out as gently as possible. This patient was raised too rapidly from head down to horizontal after a gynecological operation. There is a considerable fall in blood pressure, although the previous course was satisfactory. The change in position should be made in not less than 2 stages. The blood pressure fall due to extensive spinal analgesia with widespread vasodilatation, again with a slow pulse, will usually recover as the effects of the anesthetic wear off. If the blood pressure is allowed to remain for a long period, half an hour or more, at 85 millimeters of mercury or less, the deficient circulation may result in the development of shock. Before a high spinal block, give ephedrine or some other vasoconstrictor drug to maintain blood pressure. A low blood pressure, even if it's tolerated for the moment, leaves no margin of safety in case of such an accident as sudden severe hemorrhage. If, in spite of your preoperative ephedrine, the blood pressure falls, give oxygen. Have the head of the table lowered to assist the cerebral circulation. Inject more ephedrine, say half a grain intravenously or into the saline drip. Hemorrhage is beyond the immediate control of the anesthetist, but it's his duty to keep a particularly careful watch on the patient in any case where he notices the bleeding is severe. Treatment of operative shock is related to maintenance and restoration of the failing circulation. Intravenous drip saline is obligatory in cerebral operations, but certain other major operations, notably major abdominal, major amputations, and intrathoracic operations, may be expected to lead to some degree of operative shock. In these operations, intravenous injection of fluids is the safest method of stimulating the circulation. And intravenous drip saline given from the start considerably reduces the incidence of shock. The saline should run in at about 40 drops a minute. There is the added advantage that in emergency, no time need be wasted in changing over to blood transfusion. For these, and for all operations where the patient is already suffering from wound shock or from the effects of recent severe hemorrhage, a blood pressure record must be kept. Restorative treatment is indicated when a progressively falling systolic blood pressure has reached 90 millimeters of mercury, or in a case where the blood pressure has remained steady at 30 or 40 millimeters of mercury below normal and shows a commencing fall with a rise in pulse rate, or where the fall is related to severe hemorrhage. If the relation to stimuli is obvious, and if the clinical signs of shock have not appeared, it's permissible to watch the patient for 10 minutes or so to see if he'll recover by himself. When the blood pressure falls to the critical level, 90 millimeters of mercury, you must start an intravenous drip saline infusion at 60 to 80 drops a minute. If saline is already being given, the flow should be increased. If the fall is not checked in 10 minutes, serum, plasma, or blood must be substituted. If the fall is due to hemorrhage, or if it's already grave when discovered, blood should be given at once. Here again is our first patient, who is suffering from fully developed operative shock. Blood pressure fall is aggravated by the resulting cerebral anemia. Your first duty is to lower the head of the operating table, if that can be done without undue interference with the surgeon's work. To make quite sure the airway is clear, and to give the patient not less than 30% of oxygen. You must turn off the ether until you think anesthesia has lightened to a safe level. Blood pressure fall, whatever the cause, has the effect of deepening anesthesia. If the clinical signs of shock, pallor, coldness, sweating, have already developed when you first notice it, stop the operation until your intravenous drip is well underway. A rough guide is blood pressure 60, 120 drops a minute. Blood pressure 70, 100 drops a minute. Blood pressure 80, 80 drops a minute. Blood pressure 90, 60 drops a minute. If the response to treatment is poor, this chart shows no improvement in blood pressure or pulse rate, it's your duty to ask the surgeon to finish the operation as quickly as possible, or the patient may die. It may be possible to postpone a part of the operation to a later date. When the operation's over, the patient should be taken down to the ward, still under the personal supervision of the anesthetist.